In Africa, many people cannot access good healthcare without high out-of-pocket costs, even in countries where the government guarantees basic health services to its citizens. Sometimes, the benefits package does not cover all basic health needs. Sometimes, providers charge patients for care that should be free. And other times, providers don't have enough incentive to provide high-quality care because they get paid regardless of the quality of their services or because they are not paid in full or on time. Many African countries have multiple health schemes with many different funding sources and provider payment systems. This also leads to gaps in coverage. Governments are looking for ways to get more for the money they spend on health and make faster progress towards universal health coverage through strategic health purchasing. Researchers from a number of African countries have come together to share their experiences and better understand how health purchasing works in their countries. In the process, they have developed a common framework for assessing health spending and making it more strategic. The Strategic Health Purchasing Progress Tracking Framework is a tool that any country in any part of the world can use. It comes with resources and guidance to help policymakers identify steps they can take to improve their country's health spending and make faster progress towards universal health coverage. Strategic purchasing can't solve every health system problem, but it is an important way to achieve better health outcomes using limited resources, which means improving and saving lives.
All right, good afternoon, good morning, and good evening, whatever the time is on your side. It's great to have everyone here for this session. Thank you for lending us a piece of your time to share from your experience also and to learn from what we have learned. My name is Dare Bodurin. I'm Acting Director and Technical Lead for the Strategic Purchasing Africa Resource Center, and I'm based in Nairobi. Please keep your introductions coming on through the chat. We would love to know you, where you are from, so that we get to know who is in the room. Please get ready to engage. We are changing the conversation, and usually why we tag this theme so is because we are looking at, asking those questions that may have been swept under the carpet in the past, especially as it concerns strategic purchasing for universal health coverage. So please feel free to engage, feel free to share your thoughts, and let's have a great time. Just a few tips around the technology. You can use the interpretation button to select your preferred language. We have interpreters on the other channel in French, and you can feel free to select which is your preferred language. We suggest that you put your mobile phone on mute so that we can have full concentration in this conversation. And to ask a question or share a comment, you can use the chat box or the Q&A button just at the lower end of your screen. Usually there is the chat button there, and you would see the Q&A button also, and you can type in your questions or raise your hands, and we will certainly allow you to contribute. Yes, so I think further thoughts around this participation, we want to ensure that we are all here and we can focus on this conversation so that we can get the best of our input in the room. Feel free to also share the session highlights on social media. We're using the hashtag Changing the Conversation and Spark the Change as the official hashtag for this webinar. So we look forward to your contributions and making sure that we can have very, very fruitful deliberations. I will now hand it over to Agnes, who is an Associate Director for Results for Development and works very closely and technical lead for SPARC, also from R4D. Agnes, over to you.
Thank you, Dare, and I'm really pleased for all the attendees who are able to be here today. As Dare said, we are from the Strategic Purchasing Africa Resource Center, or SPARC, as we call it, a resource hub that's hosted by Amref Health Africa here in Nairobi, Kenya, with technical support from Results for Development. So SPARC is a go-to resource center for African countries aiming to improve allocation of limited health resources to further universal health coverage. And when we talk about purchasing, what we're referring to specifically is the transfer of pooled funds to providers. And we know that it's considered strategic when purchasers use information to deliberately direct health funds to priority populations, interventions, and services to create incentives for limited health resources to be used equitably and to be aligned with population health needs. So we say that SPARC is not just a resource center, but a movement, and we're engaging as many people as possible from all stakeholder groups from Africa and beyond to understand and talk about and advocate for strategic purchasing as a better way to make better use of limited resources for UHC. So in summary, SPARC is a hub for countries interested to improve purchasing and looking for support to do so. We're also a hub of experts who can help countries along these journeys, and also a hub with evidence on best practice lessons and pitfalls to avoid as they move along this journey that is contextualized for the African context. So today, SPARC is launching a body of work co-created with 11 technical partners in Africa that aims to understand and categorize purchasing functions in Africa. And we are doing this to raise awareness on what needs to be done to improve purchasing, to make it more strategic, and where improvements can be made across countries. So today I want to recognize the 47 authors, 45 of them who are from Africa, who contributed to this large body of evidence. They include representatives from our technical partners, the SPARC technical partners from Benin, Burkina Faso, Cameroon, Ghana, Kenya, Nigeria, Rwanda, Tanzania, and Uganda. And on my next slide, I list those technical partners in their different countries. In addition, we also had policymakers who work on these issues every day who contributed to this issue. And so I want to recognize all the individuals who generously contributed their time to contributing to these papers, all those who peer reviewed this work and improved the quality of the papers and messages therein. And I also want to appreciate the SPARC team who were involved in this work, made this launch event possible, and our copy editors and design team from RD Design. And so, you might ask, why strategic purchasing? Why are we talking about this topic? Why is it so important for Africa? Well, better than saying it myself, we have a short video that describes why the discussion of strategic purchasing is so critical for Africa and how we use our limited health resources and why it is an imperative for us as SPARC to raise this dialogue to the global stage. So without further ado, I want to introduce this video. Thank you. Many countries in sub-Saharan Africa have committed to achieving universal health coverage, which means providing all people with access to good quality health services without financial hardship. However, public funding for health has not kept pace with that commitment. It's widely accepted that more public funding is needed to expand access to health services and reduce out-of-pocket payments. The ability to raise public resources for health in sub-Saharan Africa is limited. However, at the same time, greater health spending doesn't always translate into better health outcomes. As this figure shows, some countries with the highest health coverage levels are not the highest spenders per capita, and some countries that spend the most per capita are not achieving the best results. Our paper explains how countries at all levels of health spending can make greater progress toward universal health coverage by using their limited resources more strategically. We share examples of countries in Africa, Asia, and South America that have taken steps in this direction. They have established clear institutional roles for purchasing arrangements, made sure the health benefit package is linked to available resources, selectively contracted with providers, and introduced output-based provider payment. These countries have improved strategic health purchasing by deliberately directing health funds to high-priority populations, interventions, and services, and building in incentives for health providers to improve the quality and accessibility of their services. These practical steps can lead to incremental improvement in strategic purchasing functions and policies over time across the entire health system, not just in isolated health financing schemes. As health purchasing arrangements grow more sophisticated over time, countries can achieve improved access to health services, more financial protection for families, and better health outcomes overall, all of which contributes to progress toward universal health coverage.
Thank you so much, Agnes. That was a really great opening framing for the entire conversation. We will now go into the first session of our discussion, and it will start with a presentation from Cheryl Cashin, who is Managing Director at the Results for Development and a technical resource person on to SPARC. After which would be followed by a panel discussion that will be moderated by Shekna Ture. Cheryl, over to you.
Thank you, Dari. Good afternoon, everyone. Good morning, good evening. It's really such a pleasure to be here today and to share this work with all of you that has been occupying many of us for more than a year to bring this out into the world. It's been an honor and a pleasure to work side by side with Agnes on the co-editing of this special issue, and with all of our partners and authors who have done such an amazing job of getting such detailed evidence on strategic purchasing available to policymakers, decision makers, and others to continue on this journey and make progress for universal health coverage. I wanted to spend a few minutes just setting the stage, how we approached this work, how the framework came about, how we used it, and some of the very high-level findings that will set the stage for all of the deeper discussions that you'll hear from our panelists during the rest of the session. So as Agnes said, SPARC has as one of its objectives, bringing practical evidence and information to policymakers to raise their awareness of this very powerful toolbox of strategic purchasing, and to give them some practical evidence about how to move forward and improve purchasing in the context of Africa. So that is really the starting point of this body of work, was to give a baseline. What is the current situation of strategic purchasing in Africa? Where is their progress? And how do we know how to continue to make progress and overcome some of the obstacles? Next slide, please. So we started with just forming a common language across all of the partners who are working together on SPARC to generate this evidence, starting with a common language, a common definition of purchasing, using a very standard definition that purchasing means the allocation of pooled funds on behalf of the population to the providers of healthcare services. And to make that strategic, all systems carry out purchasing if there are pooled funds for healthcare. But to make it strategic, it means making deliberate decisions about how to allocate those funds, which services to buy from pooled funds, which providers to engage to deliver those services, and how to pay them. And making these decisions very deliberately based on your priorities, objectives, and the information available. And this is one of the core health financing functions that can be leveraged toward universal health coverage. And we have some really important knowledge now about how to move in the right direction for health financing. On the revenue side, moving towards more reliance on public funding sources instead of out-of-pocket payments, which are a problem for access to services and equity. Reducing fragmentation and pooling more of health funds to make it possible to redistribute to people who need those funds. And then moving towards more strategic purchasing to align the funds that you have and incentives with your objectives. So with that kind of common understanding, common language, this group of experts that were affiliated with SPARC at this time came together and looked at the available frameworks that were there to analyze, to assess, to describe purchasing arrangements in their countries, and took those frameworks and said, we want to build something that is very practical, that will help us understand the purchasing arrangements in our countries in a way that can point to what we need to do to make progress. So based on the existing frameworks that were available, the group came together and decided to describe purchasing in the way that the functions are organized. So the core functions of purchasing, defining the benefits, specifying the benefits, the services that you're making available to the population, how you contract with providers, how you pay them, and how you're monitoring performance. So that engine of strategic purchasing is the starting point for this framework. And then recognizing that those functions are carried out in the context of governance arrangements, institutional arrangements, and how all of that comes together in the context of the system. And there are many factors outside of that that will affect whether or not purchasing is effective. So we need to also understand those and describe those factors and how they can be addressed. So this whole system comes together to be brought to bear on the direct outcomes of purchasing. Purchasing can directly affect resource allocation, incentives, and accountability. And if you get those right and improve those, then you can have impact on the intermediate and ultimate objectives of universal health coverage. So that was our starting point, and applying this framework in all of the countries, and you'll hear a lot more about that today, we were able to understand how the purchasing arrangements are organized in the countries, understand what's working well, where there's progress, and what are some of the obstacles that need to be overcome. And some of the big picture lessons that came out of the application of the framework. The first that was very clear is the functions of purchasing that are carried out by different institutions have to have very clear roles and responsibilities. If there are multiple agencies, multiple institutions, all of them carrying out different aspects of purchasing, how that fits together, how that aligns, how that overcomes fragmentation is a very important precondition for your other purchasing functions to be effective. We also generated some lessons about the purchasing functions themselves. It became very clear looking across the results across the countries that specifying the package of services that you're prioritizing to purchase with pooled funds is the starting point. It really is the precondition for all of the other purchasing functions to work well, knowing what you're buying, and then organizing your contracting, provider payment, and performance monitoring around that to make sure you're getting what you want to buy for the population. We also found that contracting arrangements are a very powerful tool. We think about contracting often as being a formal agreement between the purchaser and providers that specifies a lot of detail, and that is the case in some countries. But even when contracting is less formal and maybe is kind of looser agreements or memorandum of understanding, whatever it is, it's an opportunity to set expectations and to communicate those expectations between purchasers and providers and hold both sides accountable. It's a very, very powerful tool, and we're seeing a lot of countries start to take more advantage of contracting. We learned that provider payment is a more challenging aspect of purchasing to make progress on, but there's a lot of progress that we're seeing. And where the countries are making progress, they've started simple, a simple change from input-based to output-based payment, and some bundling, so not a very highly fragmented fee-for-service system. Some bundling of output-based payment is the best way to start on the pathway for progress in provider payment. And then finally, looking at performance monitoring, not as a punitive function, not as a way to find providers who aren't doing well and punish them, but use this again as a communication tool and a way to bring together providers and purchasers get information and feedback so that the goal of improving the system can be met. And then finally, I think as we go out throughout the conversation today, we have some high-level messages about how to sequence the improvements in purchasing. We are going to see a lot of progress today. A lot of this progress is incremental. We don't see big bang reforms, big bang changes to purchasing that all of a sudden makes everything work well. It's a challenging journey. And you can start making progress by mapping the journey. Where do you want to go? How do you want to solve the problems in your system step by step? Mapping that journey, having a vision, and making sure the incremental steps that you're taking are going in the right direction. The second big lesson is that we found that the vast majority of funding that is pulled for healthcare in Africa still sits in the government budget. Even when there are national health insurance systems in place, the majority of funding continues to flow through the budget. So we have to continue to find ways to leverage the budget for strategic purchasing, find the flexibilities that exist in public financial management systems, find all the different ways that are possible to use those purchasing functions more effectively, even in the context of the government budget. You'll hear a lot today about fragmentation. We found that fragmentation is the #1 obstacle to making better use of health funds. And there's a lot to do on this agenda to reduce existing fragmentation, to overcome it. But the message here is, first, do no harm. Don't add any new fragmentation to the system if it can be resisted. And then look inward and how to take steps to reduce the fragmentation that's there. The last message that I think is an obvious one, but is worth saying, we have a lot of joint learning that came out of this. Purchasing is a technical challenge, but it also has a lot of institutional issues, political issues, and the best way to understand and get evidence about how to overcome those is to look at the experience of other countries nearby who are facing similar challenges with similar contexts, learn and overcome those challenges together in this collaborative learning approach, which we'll hear more about today. Thank you so much.
Yes, thank you so much, Cheryl, for that presentation. I will now turn it over to Sheikna. Sheikna Toure is the Programs Director at R4D and currently seconded to Amref as a Senior Health Financing Advisor. He will lead a session of panel discussion, which is the first of that session in this webinar. Sheikna, welcome.
Thank you very much, Dari, and thank you very much, Cheryl, for this really insightful framing. Good morning, good afternoon. It's my honor, a pleasure to facilitate this panel. My name is Sheikna Toure, Health Financing Director at Financing Advisor at SPARC. I think we all will agree that making value for money is a concern of every single health financing stakeholder, isn't it? So now the question is, how do we get there? And for me, one of the biggest obstacles is our limited understanding of the kind of multifaceted reform that is taken to be a strategic purchaser. And the beauty of the concept of strategic health processing is that it's taking a holistic approach to unpack and understand the complexity of the health financing system. So for me, such fine understanding is really key to activate strategic purchasing within a given health system. And the progress tracking framework on that regard really provide a very practical and powerful tools that helps structuring our understanding of this topic, important topic. Now that it's been used in various countries and various settings, what we're gonna do now is to listen to those who applied the framework across Africa, so that they can share the findings that were generated and help all of us to better understand the current studies of strategic processing, health processing. So allow me to introduce our panelists. Today, we have three incredible, very respected researchers working for SPARC technical partners. Let me start with Sister Eugenia Ampofa, and I hope that I'm not just shouting her name. Otherwise, it's going to be a shame for me. She's from Ghana. She represents Kwame University of Science and Technology. Welcome, Sister Eugenia.
Thank you very much.
We have Joel Kandreboego. Joel works for a Burkinabe research center called RISAD. Bienvenue, Joel. Thank you for being here. And last and not the least, we have Stella Umuhoza. She's Rwandese and represents the School of Public Health at the University of Rwanda. Welcome, Stella.
Thank you, Shekina. Thank you.
I know that we have only 30 minutes, but a lot to cover. So I would like just to ask our panelists to be as concise as possible so that we can finish also on time. But last thing I would like also to really share with you is we want this session be very interactive. Therefore, I encourage participants really to interact with us, to interact with our panelists, to share, their experience, their knowledge, using the chat function or a Q&A function. And again, there is a simultaneous translation, so just to choose the language you are most comfortable with. Without further ado, I would like to start with Stella. Stella, what are the key issues that obstruct strategy processing in Rwanda? What are the opportunities to improve them? And by the way, what were aha moments when you realize a particularly overwhelming aspect of strategy purchasing through this mapping exercise in Rwanda?
Thank you so much, Shekina, for that question. It's a great pleasure to be here and to share Rwandan experience applying the framework, strategic purchasing framework in Rwanda. I would say that, give a bit of background that in many literature and also looking at the local evidence that CBHI community, the CBHI community of insurance in Rwanda, it's one of the largest scheme that covers the informal sectors and also that cover more services in public health sector. And if I give a reference, last year, 2021, more than 85% of Rwandan population were covered through CBHI. But through the application and of this framework, we realized that CBHI has been able to sustain a high coverage over many years. But at the same time, the CBHI is struggling financially because there is a very high demand to cover more services at the tertiary levels. But also there is also a high from the management of the scheme to get more funds, to get more public funds to cover more services. This is because there was issues around financial sustainability of the CBHI scheme. So therefore, the issue includes application of roles. In Rwanda, there are some roles around CBHI, benefit package, task are done Ministry of Health, and then the payment and the provider payment design also are strategies and mechanisms are set by the Ministry of Health, and now the CBHI is there to pay and reimburse facilities. So that there was that deprecation and also a bit of conflict around some of the strategic purchasing functions. But with time, we have seen Ministry of Health and RSSB managing the CBHI coming together to do some harmonization. And currently the harmonization is about how can we increase government subsidies, at the same time improve strategic purchasing functions. And now the current improvements that are happening in our setting is the improvement of how provider payments are paid. It's coming strongly, and while keeping our providers incentivized for quality of care. I will pause maybe we highlight and be able to share Rwanda's experience as we move on. Thank you.
Thank you very much, Stella. Let me turn to Joël. Joël, quels sont les principaux obstacles à l'achat stratégique au Burkina? Avez-vous identifié des opportunités qui peuvent permettre de les surmonter? Et au demeurant, si tu peux aussi partager des moments d'illumination sur des aspects particuliers de l'achat stratégique que vous-même, personnellement, vous ignorez avant l'application de ce cadre d'analyse-là.
Ok, donc merci Chekna et bonjour à tout le monde. Et donc il faut dire qu'au Burkina, on a appliqué le cadre à 5 groupes de politiques, donc à une politique de gratuité des soins pour les femmes et les enfants de moins de 5 ans, et également à tout ce que l'État finance comme frais de fonctionnement et d'investissement pour ces structures sanitaires, donc que nous appelons crédits délégués et crédits transférés. Et on a également appliqué le cadre aux mutuelles de santé, aussi bien à base communautaire, donc à base professionnelle. Mais je vais focaliser la discussion sur le financement de l'État, donc le financement de la politique de gratuité et également les crédits délégués et les crédits transférés. Donc, il faut dire que les gros obstacles, c'est la rigidité donc des règles de finances publiques. Parce qu'on sait que pour les changer, ce n'est pas toujours facile et ça nécessite de grandes réformes. Donc, ça fait qu'il n'y avait pas beaucoup de flexibilité. Voilà, donc pour changer ces règles, alors qu'on sait que quand on parle d'achat stratégique, la flexibilité, c'est un élément qui est très, très important. Donc, quand on parle d'achat stratégique, on parle également de dispositions contractuelles. Et comme c'est l'État avec ses structures, donc ces contrats sont implicites et pas toujours explicites. Donc, il faut des mécanismes de redevabilité très, très importants. Donc, ce n'est pas toujours le cas, ou même quand ces mécanismes sont prévus, donc les appliquer n'est pas toujours évident. Donc, ça, c'est également une faiblesse qu'on a relevée. Et le dernier élément que je vais soulever, c'est tout ce qui est système d'information sanitaire. Donc, aussi bien les prestataires de soins avaient du mal à utiliser les informations qu'ils produisent pour améliorer leurs propres prestations. Aussi, l'utilisation de l'information sanitaire par les acheteurs pour acheter de manière stratégique n'était pas vraiment toujours évident. Donc, ça, ce sont les difficultés. Maintenant, les opportunités qu'il y a, il faut dire qu'au Burkina, on est actuellement dans la réflexion de voir comment on peut professionnaliser davantage l'achat. Je l'appelle comme ça parce qu'il y a le projet de transférer un certain nombre de régimes de financement de la santé à la Caisse nationale d'assurance maladie universelle qui est en cours de développement. Donc, il serait le super acheteur stratégique, si je peux ainsi le dire. Donc, ça va réduire non seulement la fragmentation, mais ça va également permettre, en appliquant un certain nombre de fonctions de l'assurance maladie, telles que l'immatriculation, le contrôle médical et autres. Donc, ça va permettre de professionnaliser davantage cet achat et d'améliorer l'achat stratégique. Il y a également l'initiative de certification des formations sanitaires, donc qui va beaucoup permettre d'améliorer la qualité des soins. Bon, maintenant, est-ce qu'il y a des moments d'illumination? Bon, je dirais oui. Voilà, je dirais oui dans ce sens que, en fait, avant d'appliquer le cadre, donc on avait parfois certaines a priori. Voilà, mais quand vous prenez, par exemple, que ce soit la politique de gratuité ou bien les crédits délégués, on s'est rendu compte qu'on ne part pas de zéro. Alors, on ne part pas de zéro parce qu'il y a quand même des systèmes qui sont déjà en place, même si ce n'est pas parfait. Donc, c'est toujours perfectible, mais on ne part pas du tout de zéro. Je pourrais peut-être revenir sur ces éléments plus tard, mais je m'arrête ici pour le moment. Merci bien.
Merci infiniment, Joël, pour ces réflexions très utiles Voilà, très, très, très pratique. Let me now turn it to Sister Eugenia. Sister Eugenia, I'm going to ask the same question. What are the key issues that impede strategic purchasing in Ghana? Are there opportunity to improve them? If yes, what are they? And then I would also appreciate if you can just share, some revelation moments when you applied the progress tracking framework.
Yeah, thank you very much. Hello, everyone. I'm happy to be here to share the findings of our research. We found several key issues that is impeding strategic purchasing, but I just want to talk about one, and that is the delay in the release of funds. The National Health Insurance Scheme in Ghana was founded in 2003. That is about 19 years ago. And since then, it's been covering services for the insured. Currently, using the national census that took place last year, the coverage is 68.6. That is very high. It used to be 40 during the research period, but now it has increased to 68.6. That is very good. So one important thing we found with regard to what impedes progress is the delay. The main source of funding for the national health insurance is VAT revenue. So what I mean by VAT revenue is like value-added tax revenue that is collected locally, and it uses the already existing financial revenue collection scheme, and so it's not costly to the national health insurance. But then it has to be all put in a common fund, and then after that there will be reconciliation. And then the funds that are due to NHIA is directed, it's transferred to the NHIA, and NHIA uses those funds for its operation. For years, we heard over and over again that the NHIA wasn't paying providers. Providers would complain, and some even threatened to move out or to stop providing services to insured patients. But then during our research, we found that the delay is not necessarily from the NHIA, but the delay is in the release of the funds from the Ministry of Finance to the, of course, Ministry of Health, NHIA. And the problem is that this was actually impeding NHIA from achieving the very purpose of its existence, that is to provide financial protection. Because NHIA was not, the Ministry of Finance was not releasing the funds, NHIS was not paying providers, and providers were charging insured patients. So instead of they getting the protection, they were exposed to risk, the risk that they were trying, the scheme or the whole institution is trying to protect them from. They were exposed to it, and that was something that needs a lot of attention with regard to the transfer of funds from the Treasury to the NHIA to ensure that the system actually works and there is no interruption. If it's possible for the transfer to work, like to occur automatically, I think that would be a very good approach to reduce this delay, because it has reduced the reputation of, impeded the reputation of NHIA. And so that is one important issue that we found is impeding progress and is exposing the insured to risk, the risk that we are supposed to be protected from. Basically, I will end it here, and then I'll be happy to talk more about it later.
Thank you very much, Sister Eugenia. And that portion, in the funding flow is really important, because we need funds to flow down to the provider to even enhance their autonomy and be able to continuously deliver services that people are entitled. So thank you very much for sharing that. I will go to Joël. Joël, ma deuxième question, je suis au courant que vous avez organisé une espèce de dialogue politique au Burkina autour des résultats donc, de l'exercice de cartographie. Comment avez-vous utilisé les résultats du mapping de la cartographie dans votre discussion avec les décideurs politiques?
Ok, merci Chekna. Effectivement, le Burkina Faso a adopté très explicitement donc, l'achat stratégique donc, comme une réforme majeure de son système de financement de la santé et beaucoup d'initiatives sont d'ailleurs en cours donc, avec le soutien de SPARC. Et les résultats de la cartographie ont été utilisés donc, pour éclairer le dialogue politique. Donc, il s'est agi donc, pour les politiques qu'on a identifiées. Voilà. On a regardé les points faibles donc, de chaque politique et maintenant, autour de chacun de ces points faibles, donc, on a essayé de mener la réflexion pour voir comment on pourrait en fait, améliorer les choses. Donc, évidemment, il y a certains aspects où la solution est relativement facile à trouver, mais il y avait également d'autres aspects qu'on a plutôt vus comme des contraintes. Bon, pourquoi on dit contraintes? C'est pour dire que même s'il faut des changements, c'est forcément à moyen ou long terme. Donc, je reprends l'exemple de la gestion des finances publiques. Donc, c'est des règles qui s'appliquent à tous les secteurs au-delà du secteur de la santé. Et si on veut une spécificité pour le secteur de la santé, donc ce n'est pas évident et parfois c'est des textes de loi et on sait que pour changer une loi, c'est très, très difficile. Donc, on a pris chaque politique, on a regardé vraiment ses points de faiblesse et de façon collective, donc on a réfléchi ensemble pour voir comment on pourrait l'améliorer. Maintenant, l'idée, c'était de voir, en fait, pour chacune des politiques, réunir les meilleurs experts de chaque domaine. Parce que j'ai parlé tout de suite de la politique de gratuité, j'ai parlé des crédits délégués, des crédits transférés. Quelqu'un qui connaît très bien la politique de gratuité ne connaît pas forcément très bien les crédits délégués. Donc, pour tirer vraiment le maximum de connaissances des gens, donc on a essayé de faire en tout cas des groupes de travail donc, qui réunissent des gens donc, qui ont une expertise donc, des différentes politiques et qui les mettent en œuvre donc, pour vraiment tirer le maximum voilà, de leçons et le maximum de pistes de solutions pour améliorer les différentes politiques. Merci, Chekna.
Merci beaucoup, Joël. Sister Eugenia, one thing I really liked was that you not only drew up exciting findings, like the ones you earlier shared, but you formally discussed them with a policymaker. I think. How did those findings inform your policy dialogue in Ghana?
Yeah, it influenced the selection of participants. So we made sure that we had the providers and we also had those in the ministry present. So in Ghana, when it comes to providers, we group them into three according to ownership. We have the public providers, and we have the faith-based providers, and we have the private providers. Excuse me. So we made sure that there were representatives. The public providers are represented by the Ghana Health Service. And then we have the faith-based by the Christian Health Association of Ghana. And then we have the Private Health Providers Association of Ghana also represented. We had people from NHIA and from the ministries as well. And we discussed these issues, provider payment method, as well as the delay of payments. One of the reasons that also caused the delay to some extent, or caused the exposure to risk, because providers are charging the insured, is the low tariffs that the NHIA pays the providers. They complain significantly a lot about that, and especially those in the private sector, they say that they don't get any support from government, so the rates should be high enough to keep them in business. I think what came out at that forum was how much the private providers were not engaged by the NHIA for various fora for decision making. Those disseminations, they are not well represented, and so information and were not flowing well between the NHIA and those providers. Those in the private sector, probably not well organized, but probably are now better organized, and they were encouraged to organize themselves better so that their views and the misconceptions about their behaviors could be cleared. And that was taken very well by both the private and the NHIA. And with regard to the fee, the low rate tariffs that are being charged, the NHIA informed us that they're setting up a committee headed by a provider to review the tariffs and to make sure that the tariffs are realistic, subject to sustainability. So that was a very important step that was supposed to be taken by the NHIA to solve the problem. So these findings, the findings were discussed at the policy dialogue, and the policymakers got the opportunity to dialogue with all the providers at the various levels, and that was very, very productive to address these issues.
Good. Thank you very much. Stella, I'm going to ask the same question very quickly. How did you use the findings of this mapping exercise for the policy dialogue in Rwanda?
Thank you so much, Shakina. As my colleagues have highlighted, we organized a policy dialogue. It was a one-day event. It was a high-level workshop that was attended by Minister of Health, the Rwanda Social Security Board managing the main public health insurance, including CBHI, the private sector, the providers themselves, representative for development partners. And I was happy at that time, SPARC also was represented in the policy dialogue. And then we had opportunity to present the baseline evidence, because it was the first time in a country to have evidence around strategic purchasing functions. So I would say that this policy dialogue helped us to raise awareness about strategic purchasing functions, to highlight the strengths and weaknesses of each functions. And secondly, I would say that after the dialogue, I would say that we had a comprehensive understanding and a broad picture and a comprehensive understanding around this strategic purchasing functions and also other strategic purchasing arrangement that exist in Rwanda, because we presented a comprehensive and also a full report of the evidence that we got from our own context. I would say that most of stakeholders appreciated this initiative and also get to understand that we need to harmonize strategic purchasing in Rwanda. We need to formalize how we design our benefit package. We need to have a more explicit benefit package, which is linked to service guideline, especially to the updated service guidelines. We also need to make sure that our tariffs are improved so that make sure that the tariffs are linked to medical inflation, which is happening in the country. But also we need to move from fee for service. And more importantly, we need to start reviewing our benefit package but also looking at other possible payment modalities as we move forward. So currently, I would say that our findings paved the road to two important institutions, maybe governance structures. First of all, after the workshop or the policy dialogue, a strategic health purchasing sub-technical working group was created to support the ministry so that stakeholder engagement can continue around strategic health purchasing function. Secondly, I would say that our findings also are helping fraud. We need evidence. We need evidence. We need local evidence generated by local experts to inform ongoing policy reforms. So basically, I would say that presenting these results, we were all aligned in making sure that we continue to improve purchasing function in the CBHI, but also we have to look at other schemes, strategic purchasing arrangement in the country, including PBF and others. So this is the current focus as we move. Thank you. Over.
Thank you very much, Stella. We'll go back to Sister Engineer. Yeah, you explained that you use the finding with policymaker. Could you just share some concrete example of the policy action that emerged from or commitment that emerged from that policy dialogue between private, public, faith-based providers and policymakers? Just a few.
Yes.
Yeah.
Yes. So a lot came out. There's the need for the NHIA to collaborate more with the providers, especially those in the private sector. As I said, there was a lot of misconceptions. Those providers were able to clear those misconceptions. For example, they were classified or written down as those providers who use the right personnel during credentialing and inspection. But then when there's a time for them to renew their contract, they always come up with a different set of personnel. So it's like they stage their quality or their qualification to be credible. And so the NHIA and even the MOH didn't trust them. So they had to explain that mostly the private providers hire nurses or health workers who have just left school. And these usually wait for government to place them. So during the period that they're waiting to be placed by government, they will work for the private sector. And so when the government gives them appointments, they leave the private sector and join the government. And so the private sector has to look for, the providers will have to look for new health workers who are often the new graduates. This really goes against them because they built their experience and they lose. So there's this high turnover rate among the private providers. And so there was this sense that there's a need for better dialogue with the private providers between the MOH and not just MOH, NHIA, MOH, and the private providers who are now better organized and so have better voice. Now, of course, they may have demands that may not be realistic or may not be achievable by government, but the important step is the dialogue. And so that dialogue seems to be the direction that should be taken by the stakeholders at this particular moment, because their perception is important. They will speak in public against the NHIA and discourage people from renewing their membership, and impede NHIA from achieving universal health coverage. So we want to, if you want to increase enrollment, it's important that you dialogue well with the providers, and the providers have the right information for the members, and people will continue to stay on the scheme and be covered or be given the financial protection that is needed. So the commitment for dialogue was clear there. Okay.
Thank you very much, Ezelia. Thank you very much to our panelists. I know that we are running out of time. However, I think we have a few questions in the chat. I don't think we have time to discuss it, but I think most of them are directed to Sister Eugenia in Ghana, especially, and then I would suggest that you can maybe reply on using the chat function. So
okay.
Thank you very much. Thank you very much. That was really insightful. Let me stop here and then turn it back to Dari to take us to the next conversation. Thank you very much.
Thank you so much, Shekna, and thanks to Sister Eugenia, Stella, and Joel for your very, very rich contributions. And participants, please keep your questions and contributions coming. We just don't want questions. We also want to hear from you, your insight, your perspective, maybe from other countries that are not within the countries where we have worked. This will be really helpful. I will now turn it over to, we will now go on to the next discussion session, which would look at, what we have learned in terms of how strategic health purchasing had led to improvements in service delivery and achieving health systems objective. Let me bring back again Agnes to take this session further. Agnes, welcome.
Thank you, Dare. And thank you, Shekna, Sister Eugenia, Joel, Stella, for that conversation. They really brought out the findings that came out from applying the framework. And one of the things we tried to elucidate when we were trying to define the purchasing function was to understand, does purchasing actually lead to improvements in health system functions, in making progress towards UHC? And what we decided to do is we shall go one step further, not just in applying the framework, but even going back to the data we had and going back to stakeholders to find out where are we seeing improvements in health system functions, service delivery improvements, achieving objectives that are set out by the health system, and also towards progress to UHC. And now I have two panelists who will speak from their evidence synthesis looking at this particular question. One is Professor Obina from Nigeria, from the Health Policy Research Group, and the other is Evelyn Kabir from Wellcome Trust here in Kenya. And they will share their insights from Nigeria and Kenya. And for them, I have a question which you might have as well. When you looked at the evidence in your countries, were you able to identify pockets of improvements in purchasing? And then were you able to relate those improvements that because of the way we defined our benefit package, because of the way we contracted providers, because of the way we paid them, that we showed that we could demonstrate that this led to improvements in either access to care, improving financial protection, equity, efficiency of the health system. And so I'm going to start with that to Evelyn and ask if you can just speak through just top line what you found when you explored that question in Kenya.
Okay. So thank you, Agnes, and hello, everybody. So we find that Kenya has implemented several healthcare purchasing reforms to facilitate progress towards UHC. And today I'm going to focus on benefit specification reforms and specifically the free maternity care policy or the Linda Mama program. So in fact, in 2013, the Kenyan government introduced a free maternity care policy to increase access to facility-based deliveries, as well as cesarean sections, which are priority health services, and also to reduce the high maternal mortality rate. So in 2013, these deliveries were made free at all public health facilities. But in 2017, the Ministry of Health transferred the management of the program to the National Health Insurance Fund, that is the NHIF. And now this free maternity policy was rebranded as the Linda Mama program. So the revised free maternity policy or the Linda Mama program aims to improve access to maternity services, as well as to improve accountability and the operational efficiency of the program. So we find under the Linda Mama program, the benefit package was expanded to, other than deliveries, there was also inclusion of antenatal care and postnatal care. And also there was an expansion of the type of providers contracted by the NHIF to provide these services. So initially it just used to be public facilities, but now the providers were expanded to also include private and faith-based providers. So we find that implementation of these free maternal policies has over time improved access to maternal health services, as evidenced by increases in postnatal visits as well as antenatal care visits. There's also been reports of increased skilled birth deliveries as well as live births, and also an increase in the cases of pregnancy-related complications that are managed by skilled providers. We also find that the removal of these user fees, which used to be a key barrier to utilization of maternal health services, enhance protection from financial risk. However, we find that this increased utilization of maternal health services has not been sustained in some cases at both public and private providers, largely because of supply side barriers and also a lack of clarity of the benefit package on both the side of the provider as well as the public. So thank you. Over to you, Agnes.
Thank you for that overview. And we feel very well informed about Linda Mama and some of the good things happening there, but also some of the things that set them back. And I'd like to turn my attention to Professor Obina from Nigeria, and he will also give us some top-line findings of some of the evidence he was able to draw from his own assessment of certain schemes in Nigeria. Professor Obina, you can hear us? Okay, I'm going to give us a moment to just check on Professor Obina just to make sure his audio is working well. But I will go back to Evelyn as we wait for Professor Obina. And Evelyn, I know that recently we got here in Kenya elections, and we now have a new Minister of Health. And Kenya had prioritized UHC quite highly with the Big Four agenda. And so, you know, to this new Minister of Health, if you had your paper, how would you advise the new minister, Madam Minister, on how we'd be able to make improvements to Linda Mama so that it is a more impactful program that reaches out to and addresses the maternal mortality in Kenya?
All right, thank you, Agnes. I think some of the key issues that have hampered strategic purchasing include the implementation of these purchasing reforms as standalone interventions without like adequate strengthening of the supply side capacity. So we find like the supply side barriers are really a hindrance to people accessing the benefits they're entitled to, where they lack like services or drugs or commodities and equipment at the facilities that are contracted to offer these benefit package. So despite people being entitled to these services, they are still exposed to out-of-pocket payments to be able to access these services elsewhere. So it would be good to strengthen the capacity from the supply side, that ensuring availability of drugs, adequate staff and equipment. And then the other issue is around the poor communication of benefits, which leads to a lack of clarity of what services are covered from the provider side, which leads to a bit of varied implementation of the reforms, like benefit package reforms, based on how the provider interprets the benefit package. And this can lead to a bit of adverse provider behavior, like initially in the free maternity care policy, lack of understanding of what was actually covered, were antenatal care services covered or postnatal care services covered, led to under provision of these services, because providers initially thought it's just deliveries. So there needs to be a lack of, there need to be better communication to providers as well as the public, so that they don't pay for services that they are entitled to. And also there needs to be for purchasers and the ministry to find innovative ways of also informing vulnerable groups to make sure that they get information about their the entitlements, such as the poor people, people from rural and marginalized areas. And then another key issue is just the lack of financial autonomy by public facilities. So in the Kenyan context, we find that for providers, all the revenues they get could be from user fees or from the National Hospital Insurance Fund. All this money is sent to the County Revenue Fund, which is a central fund within the county. And sometimes providers may not get all these funds. So there's need for provisions to grant facilities some level of financial autonomy. And this would enable them to be able to buy some essential supplies and equipment to ensure there's provision of quality care. And also enhancing financial autonomy would also enable purchasers to use or design their provider payments in a way to incentivize providers towards good behavior, such as improving their quality of care. And I think lastly, I mentioned about the issue of delays in provider payment, which has already been mentioned by Sister Eugenia. So delays in provider payment has been an issue in Kenya, as well as the providers feeling that these payment rates are not adequate. And this leads to under provision or asking the public to pay for services that they are entitled to. So there's need for purchasers to pay providers on time, such that the payments are predictable and adequate, and would also be helpful for providers to engage, for purchasers to engage providers in the discussion around the provider payment rates, so that they stop feeling as though these payments are inadequate. Yeah, so thank you, Agnes.
Thank you. And just going back to a statement on the chat about provider payment being an issue, delays in provider payment being an issue, not just in Ghana, not here in Kenya, but in quite a number of countries, and possibly an area to be addressed going forward. I just want to check if Professor Obi can hear me now and is able to unmute himself to contribute. And we really want to hear from him and the contribution from Nigeria.
Oh.
Professor Obi, are you there? Professor Obi, can you hear us? Okay, unfortunately, it seems like he's facing some technical difficulties. We hope we'll be able to get him back later on in this conversation. But thank you, Evelyn. I think I liked how you packaged your message to Madam Minister in terms of issues she could address on the demand side and making sure the population is aware of their entitlements, and that also providers know what the rights of the population to be able to access care, and then the supply side issues. And you're very right that in strategic purchasing, what you're trying to do is create incentives for providers to provide high quality care, but you also want them to be able to respond to those incentives. So in terms of giving them the flexibility to manage their resources and able to address local needs or priorities within their health facilities. And when that does not happen, as in the case of Kenya, it means that you lose that tool or lever to be able to encourage them to change their behavior one way or the other. So thank you very much, Evelyn. I hope we do get Professor Obi at some point. But just to wrap up this section, I just want to say thank you to all the panelists that we had before, Shekna, my co-moderator, and some of the things that I had that we want to take away, that purchasing is one of the health financing functions of health systems, but we are seeing it also being used as a lever to be able to use limited resources wisely, knowing that we have limited fiscal space. And so we had, for example, in Rwanda, how sustainability issues, regardless of how much is being raised for the CPHI, that there are sustainability issues there that are being hampered, and how we pay providers, how we contract providers, how we specify benefits could be one way to be able to address that. But I also liked one of the contributions for Eugenia about these high-level issues that affect purchasing, that purchasing is one function amongst many, but in reality, there are those issues beyond purchasers' influence, such as how revenue is raised, public financial management, and the rules that are used to use resources at the facility that might impact how well purchasing works. But I also liked that I had consistently across all the panelists how they use this framework to advance dialogue in their countries, to bring back the findings, bring stakeholders to the table to address the issues and develop consensus on solutions that can move forward. And we had this from Joel in Burkina Faso, in Rwanda, where there's a technical working group, again with Ghana, and even bringing the private providers. And of course, the evidence that Evelyn brought us from Kenya, in that there are some good things that work well, but there are also some things that need to be strengthened. But also looking at the reality that although there are these good things, one of the reasons that they don't lead to wider system effects is because of how many different schemes are channeling resources to providers and how that blunts the effectiveness of purchasing. So I want to stop there because we have another panel coming up. And so I'm going to invite, we hand it back to Dare, who will lead us through the next session. Thank you.
Yeah. Thank you so much, Agnes. Thank you, Evelyn, Professor Obina. It's a pity we couldn't hear your voice, but let us know when you're able to hear us and get back into the panel and into the conversation. And, you know, it would be great to still hear some of your insights. All right, thanks a lot, everyone, for staying for this long. We are getting closer to, I think, the last panel for this webinar. And the next panel is going to be taken by Dr. George Kimathi. Dr. George Kimathi is the director for the Institute of Capacity Development at Amref. SPARC, being a capacity strengthening focused initiative, is actually housed within the Institute of Capacity Development. So it's great to actually have Dr. George here. So I will just turn it over to George to take over and introduce the panelists for this session. George, over to you.
Dari, thank you. Thank you very much, Dari. And thank you to Shekina and Agnes for a very, very insightful session on how countries are deploying findings from the process tracking framework. I think there are lots of progress from across all the countries. And then on the chat here, I realize there's a lot of interest to learn from neighbors, as we always say in SPARC. So lots of learning also happening. So thank you. Thank you for that really insightful session that you led us. And in the interest of time, allow me to get into our next session. So which connects really well with what we've been discussing and asking ourselves the question of where is the future of and direction of strategic purchasing in Africa? So I have two distinguished colleagues here who have joined us for this session, and I will take just a minute to introduce them. We've Rodrigue Cohn from Benin. Rodrigue is the Deputy Director of Benin's AMAC program, which is a flagship program, which is supporting the delivery of UAC in Benin, particularly focusing on health insurance. That's what Rodrigue does. And then we have Elizabeth, of course. Most of us, I know, have met Elizabeth. Elizabeth is a faculty within the Department of Health Policy Planning and Management at Makerere University, but she's done a lot of research, of course, in areas of health economics, health policy, and of course, health systems management. And she works very, very closely with the colleagues within ministries of health and other departments in Uganda. So these two colleagues will assist us to understand what policymakers are looking for, which is so important. Therefore, I want to encourage all of us as well to chime in and post questions or comments on the Q&A and chat box, of course, which is important. So allow me then to get straight to our conversation with Rodrigue and Dr. Elizabeth, and allow me to start with you, Elizabeth. In your many years of engagement and even currently with policymakers, what are the kind of supports that policymakers are looking for to improve their strategic purchasing work in our countries? And I know you have experiences in Uganda, but also feel free to share your thoughts around what you've realized as needs for policymakers in the region as well. Elizabeth?
Okay. Thank you, George, and good afternoon, everyone. So what are policymakers asking? Policymakers are interested in meeting the targets, SDG targets, and so on. And so they really want to find out how they can use the resources they have more efficiently. we've talked of how government funds are the best funds to use, but they're restricted. So often there is strong fiscal control and limited autonomy. And so they're trying to balance those two. But they're also trying to get their providers to be more productive in terms of the work that they do, to also provide quality resources out of the limited resources that they have. And so they're looking for answers to that. There is also a call to use the private sector more. And it's a reality that we have private sector providers and public sector providers in many of our countries in Africa. And so there's an issue of how best to use those providers. So the issue of strategic health purchasing answers their concerns very well. And I'll just highlight two questions or two areas where more support can be provided. One is in helping policymakers understand better what strategic health purchasing is all about and how it can help them provide services more efficiently. And two, also providing more support by using a practical systems thinking approach that links together the different aspects of strategic health purchasing. Cheryl earlier talked about benefit specification, aligning those benefits that they want to provide. Those benefits we are attempting to meet through the UHC agenda with the contracting arrangements that exist. These different areas together. So they have scarce resources, they have unlimited priority needs, they have multiple funders, government, donors, households, they have multiple providers, which means we need to see how to bring these aspects together and also the actors together so that we can dialogue and make progress. So that is one area of support. The second and last one that I'm mentioning right now is the need for data. When we talk about aligning payment to priority needs of the population, aligning payment to provider performance, there is a need for data. So when we have presented this kind of work, the policymakers have asked us, tell us what we need to add to our resource allocation formula for us to be able to purchase services more strategically. So provision of accurate disaggregated data on provider performance and also on the costs of providing those services in the public sector and in the private sector, but also accurate timely data on population needs that they can actually use to allocate the resources. That means we need to go beyond having these discussions as health financing specialists, health system specialists, to also bring in those in health informatics, to also bring in those who are collecting information on these population needs, because this data is scarce, this data is not interlinked. And so practically many of them find that they don't have the data that they require to implement strategic purchasing effectively. So the willingness in many places is there, but these constraints in terms of data and knowing precisely what to do and how to do is limited. A lot of experience that we have is from countries that are a lot more developed than our own. Yeah, I'll stop there. Thank you.
Oh, thank you so much, Elizabeth. That is so insightful. And a strong case there for data, which makes a lot of sense. And the need for us to not to close ourselves within the financing crab, as it were, quote unquote, but to ensure that we cut across all the other colleagues. We look at it from a multi-sectoral lens if we are to optimize the benefits of strategic purchasing. Rodrigo, I want to come to you, and because you sit in a strategic role in the Benin. And I believe also, specifically even for you as a policymaker, plus also your many years of experience in senior roles within the ministry in Benin, what is your need, and how can we support you? What kind of support do you require to effectively deploy strategic purchasing in Benin. If you could share that with us, Rodrigue.
Merci beaucoup. Je voudrais rectifier, je suis conseiller technique aux soins de santé primaire du ministre de la Santé et non directeur adjoint comme on m'a présenté. En fait, c'est une question très pertinente parce que la plupart du temps, quand on regarde nos différentes politiques d'achat stratégique, ça s'apparente comme le saut dans l'inconnu. Le politique, il a envie, du point de vue des engagements internationaux qu'il a pris ou du contrat moral qu'il a avec sa population, il a envie de faire vite et surtout de capitaliser sur le front électoral. Et donc, pour les achats stratégiques, il se pose deux grands domaines d'incertitude à son niveau. Le premier grand domaine, c'est la phase de la conception du modèle des achats stratégiques. Et vous allez constater que quand je prends le cas du Bénin, il y a eu beaucoup de politiques qui ont échoué parce que le modèle qui est la conception à la base n'était pas bonne, que ce soit les politiques de gratuité, les politiques d'exemption pour les indigents qui ont été conduites pendant 2 décennies. Ces politiques ont échoué parce que le modèle d'achat stratégique qui a été mis en place n'était pas le bon. Le deuxième domaine où le besoin d'accompagnement pour l'achat stratégique est nécessaire, à mon avis, c'est le début de la mise en œuvre. Une fois la politique conçue, comment dès le départ, il faut éclairer le politique pour qu'il réussisse sa mise en œuvre. Ça, pour moi, surtout de par les expériences des autres pays, les éclairages que les experts peuvent apporter, ça constitue un intérêt pour le politique et surtout, ça va le rassurer, sachant que les options qu'il est en train de faire, les choix qu'il est en train de mettre en œuvre sont également déjà expérimentés ailleurs avec plus ou moins de fortune, plus ou moins de succès, avec des incertitudes qui ont été clarifiées par les sociétés savantes ou les chercheurs. Cela permet à ce qu'ils puissent mesurer la pertinence et la justesse de ces choix et surtout d'opérer des orientations nécessaires pour ajuster les ajustements nécessaires. Il y a un autre domaine qui se pose, surtout lorsque on conçoit la politique, on commence toujours par la mettre en œuvre au niveau du secteur public. Le domaine du secteur privé, surtout libéral, est un grand inconnu et une problématique. Ma prédécesseur a souligné cela. C'est pour l'heure, au niveau de la plupart de nos pays, un grand domaine où les politiques sont perturbées et voudraient avoir des éclairages, des connaissances ou des appuis des sociétés savantes ou des chercheurs comme le pôle de SPARC. Merci.
Thank you. Merci beaucoup, Rodrigue. Thank you so much for your reflections. And you raise a critical question here around the private sector, and I'm tempted to check with Elizabeth. This is an important question that Rodrigue is raising on how we can support policymakers to navigate the private sector as well and to bring them on. Any experiences, Elizabeth, from Uganda that you wish to share very briefly?
Just to say that is a question that is coming up even here in the experience that I would share probably comes from what we've seen the Uganda Catholic Medical Bureau doing. We found that one of the challenges with the private sector for those who are not within a particular umbrella organization is that there's a lot of diversity in terms of how they're organized, how they're managed, how they provide their services, and so on. And so when you have private providers who are within an organized umbrella body, in this case, the Uganda Catholic Medical Bureau, they've been able to streamline the management approaches that are used to streamline the outputs to ensure that priority data is being collected and steps are being taken to improve that. Whereas we also have here in Uganda a private healthcare federation that attempts to bring together the different providers. But this federation does not, one of the challenges they've had is having adequate resources to allow them to actually be able to support the different providers who are part of their network. That aspect of providing them funding has been absent. And so they've noted the need to provide more supervision, more mentorship, but there is a gap in that area. So the key lesson I'm bringing forward is really the fact that, yes, the private sector is there, the private sector is available. During the COVID pandemic, we saw them play a very huge role in terms of providing those supplementary services, but we need to work out a system of organizing them so that government can be able to work with them more effectively. And there are various mechanisms of umbrella organizations that can bring them together, and wherever this kind of mechanism has been in place, you've been able to see some success. Sometimes there are particular chains that bring together private sector providers to provide particular services, and you see success. So yeah.
Thank you, Elizabeth. Very, very useful. Thank you. Lodrida, I want to come back to you, connected to what we've been discussing. And because one of the key strengths of SPARC is to be as responsive as possible to the needs of policymakers, and also to learn. That's key for us, to learn. And as you said earlier, the experiences that we are extracting from the policy journeys of various countries, when pulled together, present a rich source of learning for all these countries. So I want to ask you, Rodrigo, so what should SPARC, what are some of the key areas that SPARC should focus on in terms of our learning agenda, in order for us to be as responsive? What are those areas that we should not miss as we craft our learning agenda, and areas that will be as responsive to what you are struggling with as possible?
Merci beaucoup. Je pense que le premier domaine qui est très intéressant pour SPARC est d'accompagner les politiques dans le design des paniers de soins inclus dans les politiques d'achat stratégique, parce qu'on voit un peu partout que les paniers de soins sont diverses formes et ne sont pas toujours adaptés aux besoins de la population. C'est vrai que le politique, entre l'envie de satisfaire les besoins de santé de la population et les ressources dont il a à sa disposition, se pose la question de savoir qu'est-ce qui m'importe le plus et qu'est-ce que je peux rapidement adresser comme panier. Donc, la question du panier de soins est une question très importante. La deuxième question qui intéresse le politique, c'est l'acceptabilité du panier. Vous voyez, quand je prends mon pays, le Bénin, avant que nous ne soyons actuellement en train d'expérimenter l'assurance pour le renforcement du capital humain, nous sommes passés par plusieurs phases. L'avant-dernière phase, c'était le régime d'assurance maladie universelle où le politique avait retenu un panier, mais ce panier n'avait pas du tout reçu l'adhésion de la population. Conséquence, il y a eu très peu d'adhésion, moins d'1% d'adhésion, et cette politique a été un échec. On est parti de ces insuffisances pour apprendre afin de maintenant mieux orienter la politique qui est en cours actuellement et qui a fini la phase pilote, et nous sommes en train de passer à la généralisation. Donc, l'acceptabilité du panier par rapport aux volontés de la population, c'est important de creuser pour voir à la fois qu'est-ce qui est soutenable et qui suscite l'adhésion des populations. Le troisième élément que je trouve au niveau qui serait un domaine intéressant pour SPARC pour accompagner les politiques, c'est la soutenabilité des paniers. C'est vrai, actuellement, il y a beaucoup d'analyses de soutenabilité qui se font, mais ces analyses ne sont pas toujours approfondies. On est surpris parfois que entre les travaux préparatoires du départ, les conclusions des consultants qui orientent ou conseillent et la mise en œuvre, il y a un grand fossé. Donc, la soutenabilité du panier par rapport au financement des politiques d'assurance est une question qu'il faut adresser particulièrement sur le volet ticket modérateur. Quel est le ticket modérateur susceptible de susciter l'adhésion du plus grand nombre au niveau, à l'échelle nationale d'un pays? Au subsidiaire, la question de l'équité est également une question importante parce qu'au fur et à mesure qu'on met en œuvre la politique, et on découvre que l'équité devient un problème central et on se demande mais quelle est l'option la plus utile pour qui serait adaptée aux différentes quintiles de la population, par exemple. Ce sont des questions, à mon avis, qui méritent d'être suffisamment adressées par SPARC pour accompagner les politiques dans le choix des politiques d'achat stratégique. Merci.
Lodi, thank you so much. Those are really well thought out areas that SPARC needs to focus on. The benefits, the appropriate benefits package, the acceptability. You raise very critical questions here. Acceptability, how do you ensure the benefit package is acceptable by the population? But also, do we ensure that it is sustainable? I think that's really important. The motivation for the population to get enlisted. And the whole important question of equity, you are very right, even as you roll out a scheme like what you're doing in Benin. So thank you for that, Roger, most appreciated. Elizabeth, I want to pose the same question to you. Are there certain research questions or learning questions that we should prioritize as much as possible within SPARC, and that will speak to the struggles and the pain points that policymakers are experiencing every day? Elizabeth?
Okay, thank you. So I want to point out 4 particular areas, beginning with the private sector that we have just talked about. The tendency in the past has been, for public funds to mainly be used to, fund or support public providers. But it's clear that there are locations where we already have private facilities and we don't have public facilities. And making best use of the money demands that you work with those private providers rather than setting up other units. And so one of the questions is how to work with the private sector more effectively to deliver priority services. So looking at the kind of contracts that need to be put in place and that can allow us to balance, the need for profit. If you set a health facility up as a profit-making entity, that is important, but also balancing it with the outputs that are required and the issue of equity that always comes in. That is something that has been a challenge, but also having a better understanding of where the private sector has a competitive advantage and where the private sector is more suited to provide certain services within the benefit packages. The second area is around how to measure performance and to pay for performance effectively. In strategic health purchasing, it requires that performance is monitored, it's measured, it's paid for. But approaches to be able to do that effectively in our setting are restricted. And many countries have piloted performance-based financing, and some of them are trying to streamline that, within their public sector. Uganda, for example, is at that level of trying to streamline performance-based pay within and to make it one of the payment mechanisms. And how to do that effectively is the challenge, the new challenge that it's going to be dealing with. So more research around that will be useful, how to avoid the delays and the bureaucracies that sometimes come with working with ministries of finance in this regard. Then the third is around how to balance fiscal control and autonomy, because we know that in strategic health purchasing, flexibility is particularly important for ensuring that the local providers can actually allocate resources to these needs. But we are also in a setting where corruption is a challenge. Many workers are not getting a living wage that can allow them to survive comfortably. And so the center is always also pushing for strong fiscal control measures that will ensure that whatever money it releases is being used effectively. But we found that sometimes this ties a rope around the providers, and they are really not able to use the funding that's available to them flexibly. And then lastly is dealing with the issue of fragmentation. There are countries that have a significant amount of donor funding. Uganda is one of those countries where about 42% of the total health expenditure is provided through development partners. So when you have that kind of setting, ensuring that you put across mechanisms that can help you deal with this fragmentation and that can allow you to ensure that the donor funding is actually complementing the public funding and is being used to purchase priority services is important. And that evidence is not yet available in abundance, and yet that is a key area. So those are some areas where additional findings would be useful in moving us forward.
Yeah, thank you so much, Elizabeth. These are very critical points here. I think we keep coming back to private sector. You're very right on how effectively to work with them. And of course, performance management, which also has been discussed earlier. And I like also your point around how to balance the fiscal control and autonomy. And finally, very importantly, managing fragmentation, particularly where the donor community is already injecting a lot of resources in the same space. And I'm sure this is going to be very useful guidance for the core SPARC team as we move forward to work with you and policymakers to sharpen the areas of learning as we move forward. So thank you so much to you, Elizabeth and Lodij, for your very, very useful reflections. And I want to pause there for this session and hand over the mic to Dale now.
Thank you very much, George. Thank you, Rodrigue and Elizabeth, for your contributions. Let me now go back to Cheryl to facilitate the closing session, where we just look at, what are the key messages that are coming out from all of this conversation. Cheryl, welcome.
Thank you, Dari. I hope everyone has been enjoying this really insightful conversation and all of the insights that have been shared. We wanted to just end the session today with some final reflections. What does all of this mean? What does it mean for how to move the agenda forward for strategic purchasing in the service of universal health coverage? And I wanted to invite some of our partners from different countries that have engaged with SPARC to share their reflections. And maybe before I turn it to the panelists, would like to invite Professor Obina, who is going to share his reflections in a previous session, but we had some technical challenges. I'll see if he's available to join us now. Professor Obi, are you with us? Okay, maybe we'll just continue on then and invite my two colleagues, Professor Fatuma and Dr. Jean-Paul, to share their reflections on all of this work leading up to today and maybe some ideas for taking this forward in your countries. Professor Fatuma.
Good afternoon, everyone. Yeah, thank you very much for this opportunity. Yeah, I see a lot of things have been said, and it's starting with knowledge understanding the context, the situation in different countries of interest, specifically how they are faring on strategic health purchasing. Then there were presentation on application. And in terms of knowledge, the emphasis was real to have stakeholders, policymakers, to understand what we mean by strategic health purchasing, and also to unveil their needs, challenges. For example, we have seen in different countries, there are issues of delays. Even here in Tanzania, we are doing very well in direct health facility financing, but other resources like basket funding, there are a lot of delays to reach the primary health facilities. There were issues of understanding when it comes to application, the benefit packages, communicating it to providers, specifically the private sectors, what they should provide, and for community, what they should expect. That has come very clearly at different levels. And even when it came to coming up with the going forward, the research question issue of private providers, how we work with them and how we manage them, this came up very clearly. I should stop here for now, then I'll continue if there is another chance. Thank you so much.
Thank you so much, Fatuma. That was a great summary of kind of the high level issues, but the practical and technical issues came out a lot, but also these issues of setting expectations and communication. And I think all of that comes back to trust, which is a really essential element of making strategic purchasing work in the direction that we need to advance UHC. Jean-Paul, I'd like to turn it to you now for your reflections.
Thank you very much, Cheryl. The context in which countries have to do strategic purchasing now is growing in complexity. I can remember what the General Secretary of United Nations stated during his speech, opening speech of the recent UN General Assembly. And we have to think to that. We have to take that into consideration in this discussion, that the world is going in fragmentation, that there is a growing set of issues that government had to address. The political resources they can leverage at international level is going in fragmentation. And even in countries, they are having issues on terrorism and security. So this discussion have to take place also at that level of complexity. And when we put ourselves in the mind of a president of a country, of a chief of a government, or a minister of health, then we can think how we have to frame this discussion on strategic purchasing to make the case that it can help him solve, for instance, insecurity, contribute, for instance, in improving trust of populations that have been displaced in the government, because in large part of certain countries, the government is denied legitimacy and access in those spaces. So what does strategic purchasing mean? In contributing, maybe not solving all the problems, but in contributing, in helping government to come back on the game, come back on having means to change things. So concretely, there are many things here that are coming as tools and resources, and mainly on learning. I would like maybe to stress that all what we are saying here is showing that there is no one bullet that can solve all problems, but still strategic purchasing as a framework of thinking and action is coming with intellectual resources to help government to frame the way they can approach many issues, to gain in efficiency, and by doing so, to gain also in effectiveness. I want to echo what Rodrigue is saying about the power of strategic purchasing also in making the benefit package more acceptable, because it will have to embrace the population in formulating that benefit package. So there are many opportunities like that the strategic purchasing as a framework bring in the discussion, but definitely there is this issue of leadership and learning, whereby local actors, country level actors can sit and really say, what do we do with this? And there as well, I think SPARC have a role to play through its partner. CIRUT is also ready to support in that discussion, in really sitting down with various actors and say, okay, what do we do with those resources? How can we concretely use it in our context to really gain back trust from populations and from all our partners? It is the time now to do it. Otherwise, I'm afraid, I'm a bit pessimist that in many countries, things are not going really in the right direction. Over for now.
Thank you so much, Jean-Paul, and thank you for lifting us up and taking us away from our narrow technical view of strategic purchasing and putting it into the broader context of improving governance and stewardship in a country as a whole. And this is one toolbox, one way of thinking that can be used to hold leaders to account and hold all the actors to account for being good stewards of public resources and delivering on commitments to the population. So I really like that very high aspiring message for this, and to look at strategic purchasing not as a technical exercise, but as a way to gain trust in the population and legitimacy as good stewards of resources and protectors of health. So I think with that, I am going to just give a few messages that I take away and want to leave you all with from this discussion today. I think we came into SPARC with some assumptions about the complexity of strategic purchasing and how difficult it is to make progress in this area, even in countries with a lot of resources, with very well-functioning public health systems. We don't see a lot of huge success stories on strategic purchasing. But I think we busted the myth that it isn't possible. It isn't possible to make progress and use this toolbox and use it effectively in Africa. There is so much progress happening across the continent, and this body of work has exposed that. And I think we have to look at the ways to make progress incrementally and go in the right direction. And so I hope the framework and the benchmarks that accompany the framework can help with that dialogue to make steps incrementally in the right direction to make progress on strategic purchasing. We have also heard about the tremendous obstacles that are there that need to be overcome. I think the obstacle of fragmentation is just such a problem in so many ways and is such a barrier to equity, to efficiency, to everything. But we can, and we're seeing how the countries that are in the virtual room today are tackling this from the bottom up. We can't maybe address it from the top down, but we can tackle it from the bottom up, and we can resist adding new fragmentation to the system. I think the other big challenge that came out today is a very practical operational one, that you can't leverage purchasing. You can't create good incentives for providers to work with you towards objectives if you're not paying them on time, if you're not paying them adequately. So that's something that really needs to be grappled with, and how to align expectations with the resources available, but then make those resources flow in a timely way to frontline providers. And just lastly, I want to say that all of this learning that we're hearing about and some of these lessons that we're leaving you with, there is a very, I think, a value in the kind of exercise that was done applying the framework in the countries. And this value that I heard and have been hearing from our partners over the past year is having an objective way to look at your system, looking at functions, not talking about schemes, this scheme or that scheme, but what are the functions that need to be in place? Looking across the system, how they're being carried out now, and where can we start? Where can we take action today? Can we look at the benefit package? Can we look at our provider payment system? Where is there an opportunity to make improvements today that will put this progress in motion and depoliticize this discussion, talk about functions, talk about progress, and all work together to get there? So I think to leave you with that and hand it over to Dari to talk about how to access this body of work and how to continue this conversation with us.
Thank you so much, Cheryl. That was a great way to wrap up. I think two things that I would want to further reiterate is, one, it is likely impossible to progress towards UHC without thinking through strategic purchasing. And the two, which is the last thing that you mentioned, is that we can start from somewhere. There is a vision, there is a destination, but we can start from somewhere. We can start making little changes that will take us through that journey. And I just want to say thank you to every participant. Thank you to the moderators. Thank you for the panelists also for joining us on this in this meeting. I think the links have been posted to accessing the resources, especially the articles that have been written by all of these very great authors and our partners. You would also see on our website the policy briefs that talk about the findings specifically from each of the countries where we have operated. Currently, there are 9 countries, and I think that very soon we're going to add a 10th one, which is going to be Ethiopia, and we're really excited about that. You would also see on our website a place where it says you can work with us, and you can feel free to let us know what your needs are, how we can also support, and certainly somebody will be in touch with you shortly as soon as we receive your message. With this in mind, I'm just going to say once again, thank you for showing up on this meeting. Please feel free to follow us on our social media pages, follow us on all our platforms so that you can get the latest on how we are progressing in supporting countries in Africa to move towards strategic purchasing as they advance towards universal health coverage. Until our next meeting, I want to say thank you again and enjoy the rest of the day. Bye.
In Africa, many people cannot access good healthcare without high out-of-pocket costs. Even in countries where the government guarantees basic health services to its citizens. Sometimes, the benefits package does not cover all basic health needs. Sometimes, providers charge patients for care that should be free. And other times, providers don't have enough incentive to provide high-quality care because they get paid regardless of the quality of their services or because they are not paid in full or on time. Many African countries have multiple health schemes with many different funding sources and provider payment systems. This also leads to gaps in coverage. Governments are looking for ways to get more for the money they spend on health and make faster progress towards universal health coverage through strategic health purchasing. Researchers from a number of African countries have come together to share their experiences and better understand how health purchasing works in their countries. In the process, they have developed a common framework for assessing health spending and making it more strategic. The Strategic Health Purchasing Progress Tracking Framework is a tool that any country in any part of the world can use. It comes with resources and guidance to help policymakers identify steps they can take to improve their country's health spending and make faster progress towards universal health coverage. Strategic purchasing can't solve every health system problem, but it is an important way to achieve better health outcomes using limited resources, which means improving and saving lives.